So my name is Mark Wener. I'm a professor at the University of Washington in the Department of Laboratory Medicine and the Rheumatology Division, and I'm one of the attending physicians in the Arthritis and Rheumatology Clinic at the University of Washington Medical Center. What is scleroderma is an excellent question, and one that, in a sense, is still being explored. So what patients experience often is tightening of the skin, and often they will also develop cold fingers when they get exposed to cold, something called Raynaud's phenomenon. And those two features of the disease reflect two different parts of the disease process. Part of it is that there isn't enough blood supply because blood vessels go into spasm, and then there isn't enough oxygen and blood delivery to some tissues. And then and that's the Raynaud's phenomenon, which is when fingers turn purple and turn white when they're exposed to cold because the blood vessels clamp off and there just isn't enough blood supply to the fingers. And that can happen in other organs in the body as well. It's most visible in the fingers. It can happen in the toes as well. The other part is the tightening of the skin, which is really a reflection of essentially scarring all over the body, fibrous tissue, kind of gristle that occurs. And we think about normal scarring, of course, happening where there's a wound or where there's been a sore spot, but this can happen anywhere and spontaneously. And so the term scleroderma comes from the Greek origins, sclerosis meaning hardening, like the sclera of the eye is the hard part of the eye, and derma like a dermatologist in the skin. So hardening of the skin is one of the first and most significant manifestations where someone says, okay, this is this disease. It's also known sometimes as systemic sclerosis. The word sclerosis has the same root, the hardening, but reflects the fact that it can be all throughout the body. So systemic, meaning many different parts of the body, not just the skin. So there's a full range. Do most patients have involvement throughout their body, or is it just in the skin? And there's really quite a spectrum. There's something that's actually quite limited, sometimes that's called limited systemic sclerosis, where it's just the fingers and the forearms, that kind of thing. It does not get very involved. Patients can have that and go for a long time and really have no other clinical features that bother them, and that can go on even for decades. Other patients, it can affect the lungs, it can affect the heart, only one heart, and can affect the gastrointestinal tract, other parts of the body. And there's even another variant we don't actually call scleroderma necessarily, something that we call morphia, where there's changes in the skin, and it can be only in a little patch or one little band on the skin. And under the microscope, if you do a skin biopsy, it looks very much like scleroderma. There's just this hardening and thickening of the skin. So there really is a spectrum of disease. Well, we don't know the causes of this disease fully. We know some clues. There is a genetic component, and we know that because if you take a lot of patients with this and then compare it with normals or their brothers and sisters or family members, you can demonstrate by the modern techniques of genetic detailed analysis of the DNA that there are some areas of the human genome, that is part of our DNA, that makes the risk greater. So those are factors that are a cause, but it's not as strongly linked with the genes as conditions that people are often familiar with that think about as a genetic disorder like sickle cell disease or cystic fibrosis. So each of these genetic factors makes a little bit of a difference, and together somehow they must be part of the cause. But we don't know all the individual triggers. Perhaps infection might be a trigger, environmental factors can be a trigger. There are some known environmental factors when people get exposed at their work to very high levels of plasticizers, for example. So people who work in a plastics factory, and kind of particularly in the old days before they knew to take care of the fumes and the exhaust and wear a mask, that could be a trigger of something that looks like scleroderma. And there are other triggers that sometimes we know can be a cause. Oil that was used in Spain that was contaminant contaminated. That contaminant made something that looks like scleroderma. So there are some features that can make things look like scleroderma that we know must trigger some of the same processes. But in most patients with scleroderma, we really don't have a clue from a practical perspective. So how do we treat this disorder? And I think you can break that down in a sense into the three different parts of the disease. There's the blood vessel part that I mentioned, where there just isn't enough blood supply to some of the organs and tissues. There's another part that's related to the scarring, where there's the thickening of the skin and so on. And there's another part that's related to inflammation. And we have, I would say, good treatments for the blood supply problem. When someone has Raynaud's phenomenon and their bloods go into spasm, we have pretty good treatment to open up the blood vessels and allow more blood supply. And there's a range of medicines that are available for treating that particular part of the disease. When it comes to the inflammation part and the autoimmunity, which is a cause of the inflammation, and by that I mean the body attacks itself, and in the process of attacking itself causes inflammation and the kind of the fire part, some of the aches and pains that other patients with arthritis get, or other kinds of inflammation. And we have a range of treatments for that. Those include drugs like prednisone or corticosteroids that basically knock down inflammation anywhere in the body, but have potentially long side effects, severe side effects when used for a long period of time. We also can use chemotherapy agents. So drugs that one thinks about for treating cancer actually also knock down the immune system, some of them. And drugs like cyclophosphamide or Cytoxan is the brand name that we think about mainly to treat cancers, but also is used to treat autoimmune diseases. And by knocking down the immune system, gets rid of some of the inflammation. And that works quite well while people take it. But it doesn't, we can't use so much as to totally knock down the inflammation, because then it makes somebody vulnerable to infection. So that's always a balancing act. Do we suppress the immune system and make people vulnerable to infection, or do we sort of suffer from the inflammation and the autoimmunity? So that's one kind of treatment. And the most, and there's a number of immune suppressing drugs, many that are used to treat patients with other autoimmune diseases or prevent organ rejection when people get a heart transplant or a lung transplant or a kidney transplant. And so we have a range of medications that are used to treat autoimmunity and immune suppression types of drugs. One of the most, kind of the strongest of that kind is transplant, where we suppress the immune system so much, we basically wipe out somebody's bone marrow and then give them back either their own marrow that's been cleaned out of the cells that seem to cause inflammation, which is basically autologous or self-transplant. And there's another kind of transplant that's called allogeneic. You give somebody else's bone marrow and essentially try to prevent that inflammation from coming back. And those are under experimental trial right now. So the third type of problem, though, with scleroderma is the scarring, the fibrosis. And we're just trying to figure out some good treatments of the scarring and the fibrosis. We're not very good at treating that aspect of the disease. So the stem cell transplant approaches, when we say stem cells, they mean different things to different people. In the kinds of transplants that I think we're talking about right now is like a bone marrow transplant. You replace the immune system and the bone marrow cells that make blood. You replace it with somebody else's bone marrow or with their own bone marrow, and kind of start over again in a sense. There are a couple of trials around the world for that. Those trials are in various stages of collecting data and analyzing the data. And there are some new trials of bone marrow transplantation and stem cell transplant that are underway. The results of those studies still have not been revealed. One of the European studies is supposed to have some preliminary data coming out perhaps later this year. There's a U.S. study that was a multi-center study all around the country, sponsored by the National Institutes of Health called the SCOT trial, SCOT, and that is no longer recruiting new patients, but still following patients. And that was a project that was largely spearheaded here in Seattle and the Fred Hutchinson Cancer Center, working with the rheumatology community in the area. There are new studies also involving stem cell transplant that are underway, both with giving somebody back their own cells as well as giving them somebody else's cells, that autologous transplant and allogeneic transplant that I mentioned before. So that's the bone marrow transplant side. The other part that's been kind of interesting is to see what happens if people have so much scarring in the lungs that they need, that their lungs aren't working. And some patients with scleroderma have had lung transplants. And if they need to do that, that still is something that we sometimes recommend if the lungs are really scarred. And there's concern because patients with scleroderma have involvement with many parts of their body. But if the lung is the main issue, it turns out that they can do pretty well after lung transplants. So that's another kind of transplant that's underway. When scleroderma involves the internal organs, depending upon what the pattern of involvement and how severe it is, it can be deadly. And sometimes people can die from the scleroderma, sadly. I would say 30, 40 years ago, the most common reason for that was because of kidney failure, because the blood pressure shoots up so high that the blood pressure essentially attacks the kidney, and it could be lethal because the kidneys were being attacked, and then when the blood pressure was so high, sometimes patients would stroke or go into heart failure because the body just can't tolerate blood pressure super, super high. Fortunately, we have better control of that process right now. That's part of the blood vessel aspect of the disease. We have good drugs that can dilate, that is, open up the blood vessels and keep the blood pressure down. So when I went to medical school, that was the major cause of death in patients with scleroderma, and it no longer is because we can control the blood pressure and control that part of it. The major problem now is scarring in the lungs, and it's a different kind of closure of the lungs. It's not like asthma where the big bronchial tubes narrow down or go into spasm. These are the small, teeny little blood vessels, and it's the little membrane where oxygen needs to pass through to get into the blood on the other side. You can imagine if it ought to be as thin as plastic wrap or cellophane, and it becomes thicker and thicker like cardboard, the oxygen just doesn't get through very well. And so that becomes the biggest problem in most patients with scleroderma that can potentially lead to shortening of their life. Well, certainly fatigue is one of the big problems that patients get for a lot of different reasons. Again, if you got inflammation in your body, there's kind of like the fire is going on, people get tired from that. If you have the scarring, think about it. It's like going around wearing rubber bands throughout your body, constricting everything. Can lead to trouble with movement, can lead to trouble with taking a deep breath. And then if you don't have the blood supply, that essentially your tissues may be starved. So in fatigue is common, and really all those mechanisms can come into play. Yeah, so natural treatments I think can work in a number of different ways and are being explored. One of the ways that the kinds of disease patterns that I haven't really spoken to you about is the fact that there can be involvement of the gastrointestinal tract. And the gastrointestinal tract, so the stomach, the esophagus, and also further down into the intestines. And you can imagine also if that gets thickened and scarred and doesn't have enough blood supply, it doesn't work very well. And then part of what can happen is bacteria can grow over in those areas that shouldn't have bacteria. So one of the interesting areas right now is an area called probiotics, where we try to give natural and potentially more helpful microbes, bacteria that kind of are good ones, and maybe they'll replace the bad ones. It's still an area of investigation, but I think it's one for which there's some early evidence that they might be helpful. Another area that I think some of us think might be helpful is things like antioxidants. But in terms of proof, does it really make a difference? Those are tough things to study. And partly the course of scleroderma is so variable. Patients differ in what the course of disease, so hard to study many different kinds of treatments, both the conventional medical treatments as well as the naturopathic and alternative ones. So I would say sometimes we don't know.
Right.
And that's frequently the case, unfortunately.
Yeah.
I think scleroderma, I would say, fits into the orphan disease category in a sense, the term meaning not so many people have it. It's sort of the 1 in a million. So not that many people have it. And so part of the reason scleroderma doesn't get as much attention is there are just not as many people who have it, and therefore they and their family members know about it, but their neighbors, down the street haven't heard of it, that sort of thing. But it is, it is part of a large spectrum of autoimmune diseases and an even larger spectrum of immune-mediated diseases. And so what is helpful in understanding scleroderma and coming up with treatments is the really fantastic progress in understanding the immune system. It's really complicated, and so it's understanding means we know a little bit about it, and it keeps getting bigger and bigger and in many respects more complicated. But every once in a while, some idea comes along that says, oh, all this makes sense now. And therefore, we can come up with a new big picture, of what we call it a paradigm, a big picture of how things work. And then that means there might be treatment, but still, there's all these different parts of it, and they all feed together. But it turns out it's really very interesting that some genes, I'm again thinking that there are a number of different genetic pieces of the human genome that contribute to this. Some genes are shared between many different autoimmune diseases. So some features are kind of general autoimmunity, and therefore the treatments that might be used for rheumatoid arthritis, which is really fairly common, or lupus, which is still unusual but more common than scleroderma, many of those treatments we think are likely to be of benefit for patients with scleroderma. And so in fact that is a substantial way in which treatments for scleroderma are tried. They're available to treat another autoimmune disease like lupus or rheumatoid arthritis. Let's try it on scleroderma. And that seems to be giving promise. Again, some of the immune suppressing approaches that are used, cyclophosphamide and Cytoxan, although it's a chemotherapy, the reason it's used is not so much because of the chemotherapy, cancer part of it, but because it's been studied in other autoimmune diseases, particularly in lupus. And so there is some benefit in that regard. But it's hard because scleroderma is so complicated. Again, it's not just the immune system. There's the sclerosis part, the scarring, there's the blood vessel part. So in a way it's an opportunity. Each one can be approached and attacked. But it also means, okay, if you knock down and treat this part, something else pops out somewhere else that could be troublesome. So it is clearly complicated. So I think it's pretty common to have a delayed diagnosis of scleroderma. And the reason is that the symptoms at the beginning aren't all that different from other disorders that are more common. So let's take the most common earliest symptom is Raynaud's phenomenon, which is where the fingers turn blue and white when they're exposed to cold. Well, mild Raynaud's phenomenon that doesn't cause too much trouble to people is actually pretty common in the population. People have done surveys of nursing students, young, pretty healthy women, and maybe up to 10 or 15% of them have Raynaud's phenomenon. It's usually not mild, not that bad, and Raynaud's is really quite common in the overall population. So the first clue in some patients would be new onset of Raynaud's phenomenon. Well, since 10% of healthy, normal people have that, okay, is that particular person who maybe has their first symptom of scleroderma, could it be scleroderma or a related connective tissue disease, or is it, well, they're now part of the 10 or 15% of normal people? And then another common early symptom is arthritis, aches and pains. Well, arthritis is very common in the population. So, and even the pattern of arthritis is different. It's not typically the wear and tear. It's more of an inflammation, more like rheumatoid arthritis. But again, rheumatoid arthritis and lupus, more common. So until there's something that points more characteristically towards scleroderma, just playing the odds, most providers would say, well, maybe you have early rheumatoid arthritis, or I can't tell, when we actually use the term often, undifferentiated connective tissue disease. Undifferentiated means it hasn't declared yet which pattern it's going to go. And there can be overlap between scleroderma and other connective tissue diseases. Connective tissue disease is that spectrum of disorder. But once somebody starts to get thickening of the skin, then that really allows more certainty in the diagnosis. And so that characteristic finding. There are also some laboratory tests that are quite characteristic. Because it's an autoimmune disease, many patients, not all, but many patients, have an antibody that is a protein in the bloodstream that it has a pattern that looks like it's related to scleroderma. So ordinarily, normal people make antibodies against the things that they're immunized to or that they've been exposed to. So when you get a tetanus shot, you make tetanus antibodies that protect you from tetanus. Or if you have a flu shot, you make flu antibodies that protect you from flu. In this case, these are antibodies directed against parts of the self, and we can test for those. And those might be some of the early clues that says, okay, this isn't run-of-the-mill Raynaud's phenomenon. This is somebody who's looking like they have scleroderma. And that can allow earlier diagnosis sometimes. But it can be tough. It can be very tough. Even among experienced clinicians who are thinking about it, say, well, I think you might have scleroderma, but I can't be sure yet. And that's not uncommon. Many different physicians take care of patients with scleroderma, with this pattern of autoimmune diseases that have arthritis as part of it. It's in the spectrum of disorders that rheumatologists often take care of. And so rheumatism is the root word. It's the aches and pains part, and arthritis and rheumatism and the spectrum of disorders related to that is what rheumatologists take care of. I came to Seattle in part because I wanted to do research on autoimmune diseases, and scleroderma is in that spectrum. And in addition, one of the real wonderful things about Seattle is the scientific community. There are actually a number of arthritis and rheumatologist specialists who have been interested in scleroderma over the years, and I think that has really helped to build the sense of a community of rheumatology doctors, myself included, that take care of these patients. In addition, because of the presence of the Fred Hutchinson Cancer Research Center, these transplants that have been done, that we've talked about, the bone marrow transplants or stem cell transplants, we really have, I would say, both an opportunity and, in a sense, I would say, almost a sense of obligation to make this available to patients in our community. So scleroderma has always been a disease that's been interesting to me, partly because of the challenge, partly because is so often the case. I learn from patients. They tell me what works for them, and I find that very helpful. But also, since we have the Fred Hutchinson Cancer Research Center, the Seattle Cancer Care Alliance, which is linked to the University of Washington, I really have felt we need to make an easy path for patients to get that form of therapy. I have to say, I was one of the doubters. I wasn't sure that that kind of treatment was going to work. But that's why we do studies. That's why we say, okay, we need to try new therapies, and having something that looks like has a reasonable chance of working, and then being able to study it and determine if it does or it doesn't, or what are the benefits and what are the risks, or who are the best patients to think about that. That's professionally and personally very gratifying. And along the way, I think that's really how I've met patients with scleroderma. I would say many of my colleagues are very good also in taking care of patients with scleroderma. It's not a monopoly by any means, but yeah, that funneling those patients that go into our studies Of course, that means we take care of many more patients who have a wide spectrum of disease. But an important motivator is, I think, we have an opportunity here in the Pacific Northwest for this advanced form of therapy. I think it has substantial potential for benefit. I think it actually is helping patients, although again, it's still research, but I think it's helping patients, and I want to make sure that I can do what I can do personally to make these forms of therapy available to patients. So research funding for scleroderma has the challenge of relatively small numbers of people who have the disease and therefore who are aware of it. So again, it's not a surprise. The American Heart Association has huge numbers, and the American Cancer Society has huge numbers, and nothing wrong with them having large numbers. Lots of people are affected by that. And in addition, the National Institutes of Health prioritizes how they're going to spend research money that come from the federal government, partly on severity of disease, partly on the number of people who have the disease and the impact on all of us, both helping us be better and can we find better treatments that ultimately save lives and save money at the same time. So the one way that scleroderma has kind of a value for research is because it's part of this spectrum of autoimmune diseases and immune-mediated disorders. Some of the things that we learn in studying other autoimmune diseases really are very helpful in understanding scleroderma. But there is a role of targeted research for scleroderma, partly to provide seed money, partly to provide support, and I think that can be very, very helpful. For example, I mentioned that one of the unique things about scleroderma is it's got the scarring part, it's got the blood vessel part, and it's got the immune part all together. Well, how are they linked together? That's a particular scleroderma kind of question. So we're fortunate here in the Seattle area. We have people who are interested in blood vessel biology. But those folks are mostly interested in general in the blood vessels that relate to hardening of the arteries and stroke and heart attacks. So getting their involvement in this part of disease, okay, a little bit of seed money might help. Or a project that I'm involved with one of our rheumatology fellows is to find a better way to measure the thickness of the skin using ultrasound. Right now, our measurement in the skin is mostly by exam and pick it up and feel it and kind of give it a pretty good measure, actually. It's called the Rodnan Skin Score, named after Dr. Gerald Rodnan, who was a rheumatologist who basically invented this a number of years ago. And it's actually not bad, but it's still rather crude compared with some other techniques that you could imagine. So if we could have a more objective, that is something that anybody could do and you get the same result, and be able to store an image, for example, that was based on an ultrasound and compare now versus later. That's the goal that one of the fellows who's working with me has. Well, it turns out that the ultrasound equipment that rheumatologists often have in their office is not really designed to get at the skin or the layers near the top. It's deeper into the muscles and the tendons and the joints. So that takes extra money. Now it's not so large a project that the National Institutes of Health is going to fund it, and it's not so small that I can write a personal check. So those are the kinds of things that a couple $1,000s can make a difference to for that kind of research. And in general, this is true for science. If we can't measure something, we're not going to know if we're really making a difference or not. So having a better measuring tool, it's like, you could either have a yardstick where you can measure things at a yard, but you can do better if you can break that yardstick up into inches and quarter inches and so on. That's kind of what we're at now. We have the Rodnan Skin Score, which is a yardstick, and we'd like to actually put inches on that yardstick, and that's kind of the goal, is that can we get a more refined measure so we would be able to know earlier, faster, and with greater precision, greater reproducibility, that we have this kind of changes in the skin. And along the way, because of the technology with ultrasound now that we're talking about, we can also look at the very small blood vessels and look at the scarring and the inflammation. So we we are looking at this and that's an area just kind of locally of interest. And that's just one example. There are many projects that that benefit from seed money, that benefit from something that can kind of get things started. And the National Foundation is clearly working on that, and I think that's a big benefit. The local chapter has been very generous in that regard as well. So, I think we are grateful for donations. We're grateful for the support. All of it is really aimed at trying to figure out how to understand this disorder, how to measure it better, ultimately how to treat it, and potentially even cure it.
Right. Okay.
Yeah. So again, we in the Seattle area have had, I would say, the good fortune of having a number of experts involved with scleroderma. Dan First, who had been very interested in scleroderma on the national scene and really the international scene, was here in Seattle for several years. And Dr. Molitor, Jerry Molitor, another colleague, was very interested in scleroderma. We have, I've been clearly involved. One of my colleagues here at the University of Washington, Dr. Greg Gardner, is involved with scleroderma patients. Another provider we had here named Julia Rhiannon was involved. She's now left and at the University of Colorado, but she was involved as well. We also have experts in lung disease that relate to scleroderma. So Dr. Ganesh Raghu here at the University of Washington is an expert in interstitial fibrosis, which is the scarring part of the lung. And Dr. Garbino at Virginia Mason also is very interested and has been involved with scleroderma patients. So I think there's really, we've been fortunate. And I would say we tend to work together. The doctors who are involved with this tend to like to work together on these projects. And so, again, from a personal perspective, it's one of the delightful things about being in the Seattle area. There's a good professional community. Again, all of us have the same goal of can we treat and cure these disorders, and scleroderma has been one of the toughest ones, I would say, but we're working on it, continue to work on it. So like many institutions around the country, one can accept donations directly. For example, the University of Washington has a foundation, and that can either go to the university overall, and the rheumatology division can accept money as a donation. The various laboratories can accept individual targeted donations for a type of research or research projects. And that's really true for most charitable organizations, basically. And all of us really are very appreciative for that kind of support. It's again, the major amount of support for research really comes from the large national organizations, National Institutes of Health, other large funding agencies. But the seed money to get started, to say, okay, this looks like it's got a reasonable approach, hard to get that kind of information without some kind of funding to get things started. And so that can be very helpful. And then I would say every once in a while it is surprising, and I think every charitable organization has experienced this, where somebody hears about a disease or hears about a problem, or has a relative or a family member or somebody they know about, and sometimes patients who have no personal connection will make a donation kind of out of the blue that the foundations or the university hears about kind of at a distance. So I would say there are many opportunities to donate, and many worthy organizations. I think I'm here at the University of Washington in part because I think it's one of those organizations that I'm proud to work at. But it's well, I've met Bonnie and Christy probably actually through the foundation originally. They've had a number of doctors over the years, and I haven't actually been involved directly with Chrissy's care, but I've heard about her because of the involvement with these some of the projects underway, and so I met her originally reading through the foundation, and there's so much energy, so much optimism, such a spark, a willingness to share her own experience and tell other people, giving them encouraging pats on the back. And I would say many patients teach all of us what spirit really means. And, spirit, endurance, optimism, accepting things that you have to accept, and then dealing with things and moving on. And some of that is the willingness to be involved with research. There's a risk. Things hopefully will do well, but it doesn't always turn out that way. So having optimistic patients makes everybody in turn optimistic around them, and having that spirit and that energy is just wonderful and infectious.